Okay, so welcome everyone to ADAA webinar, What to Do If Your Child Won't Talk. My name is Kathariya Mokrue, and I'm an associate professor in the Department of Behavioral Sciences at York College at the City University of New York. I am also a licensed clinical psychologist and the director of the Stressless program at York College. Today, you will be able to answer some of the questions during the presentation and after the presentation should we have time. But before, I'd like to introduce you to the screen for a little bit. On the right side of your screen, you will see a Q&A panel. There's a little field at the bottom of that panel, and when you click on it, you can type in a question and then hit enter or the enter key or click the icon to have your questions be displayed only to us. You should be listening to this through your computer speakers. You do not need a telephone connection, and if you've dialed in, please hang up and turn up your computer speakers. You can ask questions at any time, and we'll try to get to as many as possible. Other participants cannot see your questions, and we may not have time to get to your individual questions, so we do apologize if that is the case. We are recording this webinar to make it available on the ADAA website at a later date. And today, we will be hearing from Dr. Sandra Mendlowitz. Dr. Sandra Mendlowitz is a registered psychologist with the College of Psychologists of Ontario and an assistant professor in the Department of Child Psychiatry at the University of Toronto. She is a founding partner of the Clinical Psychology Center with an extensive clinical and research background in the area of anxiety disorders and a clinical focus in anxiety and mood disorders, with a particular focus on obsessive-compulsive disorder and selective mutism. Dr. Mendlowitz has authored several cognitive behavioral therapy treatment manuals, and she trains and supervises other mental health professionals. Now, before we begin the presentation, I'd like to tell you about ADAA. It was started in 1979, and today it is the leading nonprofit dedicated to increasing awareness and education about anxiety disorders, depression, OCD, PTSD, and related illnesses. ADAA's mission is to improve diagnosis and promote the prevention, treatment, and the cure of these disorders through education, practice, and research. ADAA fights to end stigma by promoting the message that they are real, serious, and treatable. Please visit the ADAA website. That's www.adaa.org, which includes Find a Therapist, which is a searchable database of treatment providers, as well as free educational information and resources, self-tests, self-help groups, clinical trials, and a lot more. You can support ADAA's efforts, such as this webinar series, by making a charitable contribution on the ADAA website. So now you can remember that you can type a question at any time, and I'd like to turn over the presentation to Dr. Mendlowitz.
Well, thank you very much for your lovely introduction, and thank you to ADAA for inviting me to share my knowledge and experiences in treating selective mutism. So this is the face of selective mutism. Jacob appeared in a story in People magazine in 2008, and while selective mutism has been recognized for a long time, this article really helped to bring the SM phenomena to the forefront. Jacob could really be any child. SM children don't have facial features. They're not specific to any particular culture. Selectively mute children come in all shapes and sizes and cultures. I've had the opportunity to work in a hospital that sees children of many different races and cultures and socioeconomic backgrounds. So you see that selective mutism could be your child or could be mine. So the question remains as to whether or not your child has selective mutism. And the first step in determining whether or not your child has SM is really a proper diagnostic assessment. And the first stop in this process is usually a visit to your family doctor or pediatrician, who will either make a diagnosis or send you to a specialist who has experience and understanding of selective mutism. Now, it's important to note that not all clinicians are experienced with SM. The qualified professional will conduct an interview and ask you questions, and depending on the age of your child, may ask them to complete some questionnaires. Since selective mutism is usually discovered by virtue of the fact that the child isn't speaking in class, it's important that the clinician be in contact with your child's school, especially the teacher or any support staff who may be involved with your child, so that the clinician can gather information regarding the people and the zones your child may be speaking. And we're going to talk a little bit later about talking zones, because this is part of the process of getting your child into recovering from selective mutism. So I think it's important to note that the primary diagnostic feature of a child with selective mutism is that they do not initiate or reciprocally respond when spoken to by others. They generally speak in their home in the presence of immediate family members. Sometimes they will speak to a friend in their own home, but not that same friend in the school environment. Sadly, they often don't talk to grandparents, even though they may live in the same home, and sometimes they do. So you can see that there's quite a bit of variability. The key feature with kids who have selective mutism is they have a high degree of anxiety. So you can see that from the slide that there's a consistent failure to speak, that it interferes with their life, that it has to go on for at least 1 month. And what's important but often difficult to disentangle is whether or not there are language impairments. And the reason why this is difficult is that language impairments are assessed by speaking. And if the child is not talking, it would be difficult to determine whether or not that's present. So let's turn to the myths of selective mutism. And so there are 4 primary myths which surround this particular disorder. And the first myth is that selective mutism is caused by some type of trauma. However, if we look at the research literature, we will see that the amount of trauma that appears in selectively mute children is about the same as the general population. So the issue is that they need help with anxiety, not trauma. And this is important because if you're taking your child to see a specialist, it's not trauma work which is the issue, it's anxiety management work. Another myth that is often perpetuated about these children is that they're just shy. Don't worry, they'll grow out of this. Well, if we look at the difference between shy kids and kids who have selective mutism, the difference is the following. Shy children speak within a very short period of time. This is in contrast to kids who have selective mutism. Selectively mute kids don't talk within a short period of time. Selective mutism often inhibits success academically and socially. Shyness does not. A third myth is that these kids are just being manipulative and they may have oppositional defiant disorder. Well, the truth is that they're not refusing because they don't want to talk. their refusal is secondary to the anxiety they're suffering. So in other words, the anxiety drives the inability to speak rather than a refusal. Many of these kids, in fact, would like to speak, but they often can't because their vocal cords are strained. So the behaviors are about avoiding situations because of the anxiety they would endure rather than a refusal to speak. And finally, the fourth major myth around kids who have selective mutism is that they have a speech and language problem or they are autistic. Now, interestingly enough, some of these kids do in fact have some speech and language problems. Many of them are so subtle that their parents don't pick it up. And the problem is that these subtle language deficits cannot be assessed in a rigorous manner until the child speaks. So if you can't assess you can't assess a non-speaking child, so we don't really know whether or not there are some language deficits. But autism does not equal selective mutism. The autistic myth is perpetuated because many of these kids who have selective mutism do not give or maintain direct eye contact. But this lack of direct eye contact is due to extreme anxiety. In fact, when they're comfortable, many of these kids can actually be quite sociable, and they do give eye contact. Another interesting fact, we'll just change to the facts. There are a number of different interesting facts, and one of the facts is that less than 1% of children have selective mutism. So this means that there's probably one child with selective mutism in every 5 classes at school. There's also a greater likelihood, and this likelihood is 2 to 1, of girls having selective mutism than boys. So many children who have selective mutism also have another anxiety disorder, and this anxiety disorder is usually social anxiety. So if we look at the differences between social anxiety and selective mutism, it's the following. In social anxiety, the anxiety is about being judged negatively by others. In selective mutism, it's about an inability to speak. They do not initiate or reciprocally respond when spoken to. Many of these kids, when they begin speaking, will talk about the fact that they don't like the way their voice sounds. And so that inhibits their desire to actually speak. They're concerned about how their voice will sound. And if we recall before, I was talking about the fact that there is some strain on the vocal cords. Many of these kids, when they do begin to speak, kind of squeak out their first few words. So another fact is that the onset is typically 2 to 4 years old. Now, this is interesting because a lot of these kids are not actually identified unless they attend a preschool environment, and even then, they're slow to be recognized. So despite the early onset, children with selective mutism are not typically identified until they begin school, and there is a realization that these kids aren't just shy, that their quietness is going on for more than a couple of weeks. So this is why kids who have selective mutism often do not receive professional help until they're around 6 or 8 years old. So it's important to reduce this gap between the onset and the identification, because the longer children with selective mutism go without treatment, the more difficult it is to treat. And that's the case with most anxiety disorders. Another fact that is important in terms of the treatment is that the family history of these kids is usually significant for anxiety. So the research suggests about 90% have a family history of social anxiety, and there have been studies which have demonstrated at least 37% have a family history of selective mutism. So that's quite high, and when you think of treatment and what parents might be modeling, this is an important fact to keep in mind. So what are the common features present in kids with selective mutism? And remember, it's important to be able to identify what is selective mutism versus other anxieties, because the way we're going to intervene has some impact on this. So as I mentioned before, one of the reasons why these children can often be misperceived or misdiagnosed is their general lack of responsiveness to others, the sort of staring off in space, the stiff body movements, the slowness, and overall being very timid in general. And they can frequently appear quite awkward in their movements. If we look at the way a socially anxious kid responds to, let's say, praise versus the kid who has selective mutism, we can see differences. So socially anxious children tend to like and actually often seek out praise. Wow, you did a great job. That's wonderful. They're very happy to receive that. This is not the case with the children who have selective mutism. They often shy away from excessive praise or attention. So if you're going to give praise to a child who has selective mutism, a simple smile and a quick nod can be much more effective in terms of acknowledging a job well done than a boisterous fanfare, which would result in the child's anxiety skyrocketing. So why would we need to intervene with these kids? Well, we've already mentioned that there's potential for long-term negative effects. And the bottom line is, like most disorders, the longer the child suffers, the far more entrenched will they become. And the further behind in school they'll fall. Early intervention is key. A significant amount of time is spent sitting in the school classroom. So school participation is not only an important component of academic evaluation, but also an important opportunity to learn how to express one's opinion, how to work together with other people, and how to build friendships. And we know that positive social interactions are important because they lead to positive social and emotional development in children. We also know from research that children who can interact successfully with their peers, even during the preschool years, have stronger social networks and friendships later in life and are more often included in social activities than kids who lack these skills. So your communication skills are very important. These are key implications for the future: social communication, speaking with others, the ability to negotiate and develop an awareness of how other people feel when you communicate to them are critical. So these are some of the reasons why it's important to intervene and to intervene early. So if we look at how we're going to approach the kids who have selective mutism, there are 4 main areas which we want to be involved in. And these need to be addressed in order to facilitate speech in the selectively mute child. So, as previously noted, a proper diagnosis is critical. If you don't have the right diagnosis, then you're treating the wrong problem. So diagnosis drives our treatment. Since your child's job is to attend school, and that's as I mentioned, where the majority of their day is spent, educators and other school professionals, such as speech and language pathologists, need to be involved. Now, you may be asking yourself why a speech and language pathologist needs to be involved if there's no communication problem. Well, the answer is because the child is unable to utilize their language skills in specific situations, and speech and language pathologists are key professionals in helping children build these particular skills. If we look at the anxiety component, we know that we need a professional who has skill in treating anxiety. So cognitive behavioral therapy is the evidence-based choice of treatment for anxiety disorders. So it is imperative that the anxiety management skills be integrated into any treatment plan.
I'm sorry to interject right now, but I have a question from one of our participants who is a speech language pathologist in a school setting, and she presents a question where she believes one of the child she's working with, she suspects may have SM, and mom doesn't think anything's wrong because she talks all the time. I'm sure you get this question a lot. So she must be just shy, and so it creates a very difficult situation. And the speech pathologist is asking, what is there any advice in gently informing the parents that this might be more than just shyness? I can imagine the hierarchy, and you don't want to overstep, but yet you're seeing something that is not quite right.
Right. So this is a good question, and it's always a difficult question when we have parents who don't really believe that there's a problem. Mm-hmm. And so one of the approaches that we often take is to start creating some evidence of where the child is speaking and where the child is not. And a little bit later on, we're going to talk about talking zones. Mm-hmm. And I'll be presenting an example of a talking zone. And this is a really good way to have something visual for the parents. So what we do, I'll give you a little bit of insight into this now so that we don't forget the question, and that is that if you divide the child's day up into specific areas of the school, and we look at what's going on in each of those areas, and then we start documenting daily monitoring of what the child is doing. So are they whispering in this class? Are they using their voice? Are they speaking to certain peers or not? And then if we record this, and then we present this to the parent and then begin to have a discussion about, well, is your child speaking in the house? What happens when they go to the grocery store? What happens when they go to the mall? What happens when a friend comes in the home? What happens when they go to the park? This is what's happening in school. We can look and see whether this is just isolated to the school area or whether this child is, in fact, anywhere outside the home being exceptionally quiet. Mm-hmm. And presenting these differences is often very helpful for parents. Mm-hmm. Because you can't intervene unless you can demonstrate that there's a problem. Mm-hmm. Mm-hmm. Time factor is also very important because, as I mentioned before, shy children will warm up within a few weeks of starting school. Mm-hmm. Well, if this child hasn't spoken since September and we're now into May, this is clearly a problem.
Mm-hmm. Mm-hmm. Thank you. That's very helpful to be able to keep in mind that by collecting evidence and generating a pattern, perhaps a pattern of what is happening in a child's given day, it might be useful to engage parents to have a conversation about what else is going on in the home. Is there a similar pattern? Is it different? Why is it different? How can we find out more about the reasons, the differences, and whatnot?
And it's also very interesting that often a liked peer will actually speak to the child in the home setting, but that same peer will not be spoken to in the classroom.
Right, right. Stark contrast.
So that's a good segue into my point about parents need to be involved. They need to be provided with education, and they need to provide education. It's actually often in the reverse, where parents are complaining my child isn't speaking, and they need to convince the school that it's much more than shyness. So they need to provide information, education around selective mutism, and in both cases, I think that the schools should have access to this as well as parents, and they need to work on similar goals to promote speech. Another important factor is labeling the child as a non-talker. Often when children begin to speak, they will say, well, they're not going to speak in this class because everyone knows them as a non-talker. And if they begin to speak, people will say, oh my God, you speak.
Excessive attention.
Exactly. And this is what I was talking about before, is that these kids do not like that kind of attention. So we need to move away from them as a non-talker. We need to, remark that they can speak. We need to educate people. They are able to speak. They are just not speaking. So modeling and role-playing social interactions where speech is involved is another key way that parents can intervene, as well as encouraging the child to speak by gradually exposing them to stressful situations and reminding them that eye contact is important. That's one thing that we do in the clinic if we have children who are not giving us eye contact. Even though they might not be speaking, we constantly say eye contact and we point to our eyes, and so they get used to looking at people. And requiring them always to do something. If you're not going to use your voice, then you have to mouth or put up your hands. We always start with nonverbal gestures and then move on in a stepwise approach.
Another question with regards to signs, perhaps progress or maybe indication of SM. Is it possible if a child moves her mouth very little, and this is coming from the same speech pathologist, while talking in almost an inaudible, quiet voice, as if she doesn't want anyone to hear it? Could that be another symptom or a sign that she might not want to be outed by speaking?
That's correct. That's actually quite common. And so part of what we want to do is we want them to practice with maybe one other child present. Keep reminding the child that this individual does speak and that the voice will get louder as they become more comfortable. And then it would increase that to 2 children. And we usually like the child who has selective mutism to decide, is there one particular person, if you had to choose one person to begin speaking to, who would that be? And that way they have a bit of control and comfort in their process of speaking to the entire group. We have to be careful about not allowing this to go on for long periods of time. As if you don't expect speech, you're not going to get it. We always have to have the goal that this is going to happen. And we'll talk a little bit later about how we move towards that goal. So let's address each of these levels. So the first level is in terms of assessment and diagnosis, and we've already talked about establishing the diagnosis as critical. But I just wanted to mention about questionnaires. So the Selective Mutism questionnaire, the SMQ, and you have a little bit of a snippet into it. It's on the top right-hand screen, some of the examples of questions, is actually the only available instrument developed to measure a child's frequency of non-speaking behavior across situations where the child is expected to speak. So given that this is a parent report measure, it might be useful in the terms of the question we had about the parents and the speech language pathologist is to actually give the parent this questionnaire. This might widen their own perspective on what is happening with their child, because it consists of about 17 items that quantify the degree of mutism in various social and interpersonal contexts in order to assess severity and the interference associated with non-speaking behaviors. So it looks at speaking or not speaking in the school, at home and with other family members, and in public or social settings. So using evaluative questionnaires can be very useful in looking at where a child is at point A and then later on in time. You can have these questionnaires answered again by the parents and the teachers, and then you can see where the child lies and whether there's any improvement. So this is another way to evaluate and help us assess what's going on. So let's take a look at this speech hierarchy. So this is an adaptive scale that we use at Sick Kids, and it's a small scale with very defined gradients. Usually when we see kids, they are at the complete mutism level. So they may have some nonverbal communication, but they aren't speaking.
Across various contexts.
Yes, across various contexts. So this is something that can be given to the teacher. The parent can circle where they think their child is. If the child's a little bit older, we sometimes ask them where they think they lie on the scale. Part of this is dependent upon how old the child is. But it's also a way of determining not only where your child is, but setting up goals to get to the next level. So children will often speak in the waiting room when they don't know that we're going to appear. But once we appear and introduce ourselves, they immediately become mute. So the question is, where are they in different situations, as well as where are they in school, where are they in your office. Kids are at different levels at different points in time, and it's important to capture that. I also want to point out that there's a difference between directed speaking and spontaneous speaking. So directed is when I ask you a question and you respond to me. In terms of spontaneous, it's when the child asks a question without being cued. And that's an important distinction in speech. We want to get the child to spontaneously speak. So moving along, I spoke about these evaluating zones. So selectively mute children will speak in specific zones. For example, they may speak in the school drop-off area, but not the playground. They may speak in certain parts of the hallway, but not in other parts. So it's important for you to determine what the talking zones are in the home, outside the home, and in the school. And this chart is a concrete way of evaluating what's happening in each zone and a way of establishing goals for the child. And so this is an example of the evaluating a talking zone for the school, but I've also have one for parents to do in their home. We have ones for moving outside the home. It's very easily put together, and I'm certainly happy to pass it on to anyone who would like to be able to use this. You'll notice that there are 4 key areas highlighted in each of the zones. So whether the person has no voice at all, whether they're mouthing, whether they're whispering, and whether they're speaking. So we've basically taken this hierarchy and crunched it into something that can easily be used as a checkmark system. So where is the child at this point in time, and where is the child going? And we often, in our treatment, will hand one of these forms to the teacher and ask them to complete it on a weekly basis, because our treatments are weekly. And we will also, once we have established a baseline, set up what I call as homework for the teacher to work on with the child. Because if that's where the child is spending most of their time, it's really important for that child and the teacher to be interacting.
Is the child aware that this checklist is being used to monitor the progress?
Absolutely.
Good, good.
They actually, interestingly enough, they come up with a big smile when we say that their teachers are getting homework. They think it's pretty cool that their teacher would have homework as well as they would. So if we move on to this second component, and I talked a little bit about this already, and that is the integration of school. So again, I can't emphasize this enough, but early contact with the school is critical. And our go-to person is always the speech and language pathologist, and they're there because they can assess the child's communication much better than most of us. They can treat functional communication, and they can educate and counsel families and teachers, and they tend to be able to bring everybody to the table. So having everyone work on the same goals is critical, and when we speak with parents, we always want them to be consistent in the way that they respond to a child. Well, that same advice is important in the school environment. So all school personnel must create a consistent way of responding to the child. For example, at the early stages of intervention, nonverbal responding should be encouraged by all educators. However, once this is established, the child needs to be encouraged to move on to the next level of communication, for example, mouthing. So consistency allows the child to understand what is expected. It also prevents any question of any one individual feeling manipulated by the child. So if we have everybody operating on the same level, we maximize opportunities for speech.
And how do you assess whether it's the right time to go to the next level? Is it through discussions with the teacher and the child? Because I can imagine a child might be a bit more reluctant to move on to the next stage, and they might try to stay in the zone that they're comfortable with for longer than healthy.
Exactly. Well, it sounds very easy, but it's actually not. So one of the first things we do is we send out a letter to the school with parent permission that the child is being treated here, and this is what the definition of selective mutism is, and these are the pieces that we are going to be working on. The other thing we do is we arrange a conference call. If we can't meet in person, we arrange a conference call and see where everybody is, what their expectations are, and how we're going to move forward with this plan. So we bring the players together, and we have weekly communication through email. So this is a lot of work. But if you do your work up front, you will get the payoff in the end. And the payoff is the child will be speaking. So we are quite open to receiving emails from teachers when they have questions, or parents. And our rule of thumb is everybody involved is on the email so that everybody understands what the question and the answer is. So, as I can't emphasize enough that this takes a lot of time and effort, but the goals of having the child speak are easier to achieve when everybody is on the same page. This way, we can monitor and adjust as we need to. Another aspect, and one of the most important that I spoke about before, is that the child is not labeled a non-talker, because often what we see if we don't have people on the same page is somebody saying, oh, don't bother asking them a question because they don't talk anyways. And that's probably one of the worst things that can happen. So too often when SM kids begin speaking, they tell me that they don't speak because everyone thinks they don't. And if they do speak, everyone will be shocked and single them out. And this is why you need to provide that corrective feedback. Parents need to say, my child does speak, they have a voice, and when one child says, oh, Johnny over there doesn't speak, the teacher needs to correct them and say, they do speak. They're not giving us their voice now, but they do know how to speak. Have a voice.
That's very helpful, very specific way to correct the child.
Exactly. So an issue of contention is often when we speak about rewards, because many people feel that you shouldn't be rewarded for speaking, that people should just speak. But we have to remember that rewards or incentives can be useful at times to motivate positive behaviors, especially in children. And when parents have difficulty with this, I often ask them if they reward themselves for doing a good job or at the end of a very hard week, and they usually laugh and say yes. I said, well, why wouldn't you reward your child for trying? So they can be especially useful in overcoming resistance to accomplish a very difficult task, such as playing cooperatively or using your voice or speaking louder. So the issue around rewards is that people are way too generous in the kinds of rewards or incentives they offer. And they should be something, concrete, such as an extra privilege or a special treat. They could be electronics, use of electronics, and you do this by setting up a reward chart ahead of time and taking a look at the kinds of incentives that would be rewarding for your child. Some children still like stickers, other people not so much. Electronics are usually a very good way of enticing people with rewards. But as I said, it's a good idea to involve the child in setting up the reward system.
Right, so they feel they're part of this plan too.
I'm sorry?
So that the child feels involved in their own progress, the effort that they're making, that they have a stake in this as well.
Absolutely. So in terms of treatment, part of this depends on what's available in your local area. So we have both individual and group treatments. We know that cognitive behavioral therapy is exceedingly effective for school-age children and older. And often people don't think that younger children can engage in cognitive behavioral therapy. But they can if the cognitive behavioral therapy program is modified for very young children. And there's actually some research right here out of Sick Kids that has demonstrated that very young children can, in fact, engage in a modified CBT program. And again, in these programs, parent involvement is critical. So the younger the child is, the more behavioral components have to be addressed. Because if you think about how kids reframe their thinking style, that's really reserved for kids that are 8, 9, and above. But younger children have a little bit more difficulty with that. So when you are intervening in a cognitive behavioral program, more behavioral type treatments are important and important in the approach for addressing symptoms. So these are examples of different types of interventions that you might do. And I want to just emphasize that modeling is a critical intervention, especially if a parent has some anxieties. There's a very old program called Jolly Phonics, and we play something called sound tag with children in a group, and that's basically you have non-verbally introduce the sound of letters. So S, for example, is, so we make the sound with our hand, and we make a motion of a snake for S. And we do that with a variety of different letters. And interestingly enough, we often hear little giggles coming out from kids who don't speak. It's kind of a fun, gamey approach to making sound. So the premise under which we're using these behavioral techniques is that the behavior is a learned response that develops from trying to escape anxiety. And if we give them strategies, their confidence will increase and we will decrease their anxiety, and therefore the mutism will lessen. So here's another example of how we would get to a child, how we would achieve in terms of shaping talking, particularly with younger children. So we might start by practicing waving. We would do waving and then include mouthing and etc. So we would keep adding on different requirements, rewarding effort. We would model the behaviors, and we would practice, practice, practice at every moment. So as soon as we pick up the child in the waiting room, we start our practice. We usually have a pocket full of stickers or candy, and when we get any level of response, we are immediately rewarding these kids. And we find that this is quite effective. I wanted to talk about this strategy that I stumbled upon because I found it was very interesting and it was fun. And treatment has to be fun. Part of helping your child is creative. So with one child who happened, I found out from the dad, liked to listen to the Beatles, and we were practicing on hello, goodbye, and then I remembered that there was a Beatles song, hello, goodbye. So we went to the computer and we found the words, and we used what's called a repeated loop strategy. So basically we went through, I read through it. I didn't scare him away with my voice. I did sing the song, and I began to hear language. And it was a very interesting way, quite by accident, he actually began singing the song. And this was a breakthrough point with him, and the beginning of using speech in other areas of his life, because we started with the hello, goodbye, and then we actually, he took the words to his teacher, and his requirement was just to actually say a couple of the lines, and he ended up singing it to the teacher.
Oh,
singing it together, and it was just a wonderful example of how you can just sort of use everything in your environment that a child has and a child loves to help facilitate speech. We've also done things like play I Spy, where kids are pointing and then they're mouthing and then they're using words. And these are things that you can do on the spot. Parents can do this in the car with a friend in the car with them. So you can easily involve lots of other children. So the purpose of all these strategies is to begin to desensitize the child to places where they're experiencing anxiety. And the concept is the same: practice, practice, practice. This is an example of a speech ladder, and speech ladders are ways of setting up goals, and we tend to create speech ladders in almost every session. and the kids revisit their ladders to see where they are, and we tie success to a reward system. We not only do speech ladders for children, but we also do them for parents. So, in terms of parent education and involvement, there is significant research to demonstrate the importance of parental involvement in the treatment of anxious children. And given that these children have anxieties, it's important. So when we run treatment sessions, we always meet with the child if we're doing individual, and then we meet with the parents afterwards, and we set up goals and expectations. We do the same thing in a group environment. So speech ladders for parents can be evolved around any aspect of their life. And examples that we give to parents are going to a convenience store. So the child can be with their parents initially and just mouth to someone what they would like. Then they may use one or two words. And what we're doing is we're backing the parent out of the picture so the parent is maybe just standing at the door and the child goes up and pays for an item and has to describe the item or ask for something. We also do these exercises in and around our office. This particular hospital has many stores on the lower level. I think they know us by now. We send kids in to ask where Band-Aids are and in the drugstore, and we haven't yet gotten them to order our Starbucks, but we would like that to happen.
We're higher on the hierarchy, probably the top item.
But we do have the kids order from menus in restaurants. So we can work the plan any way. We work with the parents to develop these speech ladders for them. And again, what we're doing is we're discovering what their zones are, and we're trying to expand them beyond the walls of their own home. So other strategies is using technology to your advantage. So as we wrap up, it's important to understand that technology is here to stay. So let's integrate it into our plan. There are many apps available to facilitate speech. I've downloaded interesting apps, ones that can mimic speech. The kids always find that pretty funny. Ones that make unusual sounds, and then we try and make those sounds. But these kids find it fascinating, and it really helps and encourages them to use speech. Another idea that you can use is your family albums. So as we've noted, there's a variety of very specific strategies such as formalized cognitive behavioral therapy, anxiety management strategies, but you can be creative in your interventions to effectively help and treat these kids and facilitate speech. One-to-one time with the child in the school and other environments is key, but also expanding that zone and integrating class peers one at a time. So you gradually desensitize the child to anxiety-provoking situations. These are the basics of anxiety intervention. So the key in promoting speech in the SM child starts at home by establishing speech as a requirement and then ensuring that the child obtains the skills to manage their anxiety in other environments and challenge their fears and to make them feel confident in using their voice. There are also some very good websites that people can access, and ADAA has a great website, but there's also a number of other websites, and some are American websites and some are Canadian websites where you can find useful information about how to address selective mutism.
Thank you, Dr. Mendlowitz. I have a couple of other questions that's been posted as you were talking about the specific strategies, and we're not going to get to all of them, but there is one about the role of medication for SM. What is the role, and how is it managed along with these behavioral interventions?
So that's a great question. A lot of parents are very hesitant about giving their child medication, especially because a lot of these kids present at a very young age. But medication, in fact, has a role. And we have a formula here that if the child isn't engaging or able to actually have any type of sound within about 4 or 5 sessions, we introduce the concept of medication. And we actually talk about it at the beginning, and we lay the expectation that speech will begin at session 4 or 5, and if it doesn't, then medication likely has a role. We also want to take a look at family history, because if there is a family member who has selective mutism and medication has been helpful in that case, probably medication will be helpful in the case that's presenting to us. So when we're dealing with kids who are very young, have to use medication, we look at those medications, and we're talking about SSRIs, selective serotonin reuptake inhibitors, because those are the medications of choice when we're looking at anxiety. So we look at those that are available in liquid form, so they can be titrated to very small doses. And that's often very useful. And so there are kids who do require medication, and it just takes the edge off the anxiety, so they're more likely to use the strategies.
Thank you. And we have a couple of questions about resistance, if the child is resistant to treatment and want no part of it, or if it's a very complex case where the severity is quite severe, not wanting to use the bathroom even, or eat, or never to speak. I mean, it's a very severe case. Do you think that might be where medication could be discussed as well, or are there other strategies to deal with the resistance or the severity of the cases?
So I think that the first part of the answer to that question lies in the diagnosis. So I would really wonder what's preventing this child from eating. So is there another comorbidity that exists? So is there actually an eating issue? There are sometimes. Certainly eating behaviors, unusual eating behaviors, coexist with anxiety problems. And before we jump to the medication, even when there's severity, I think that it's important to investigate the drivers. So what is the underlying issue as to why this child isn't using the washroom? Can we show the child that there's some benefits here? So it could be that there are specific rules in a classroom which are prohibitive to this particular child. So for example, you always have to raise your hand and ask, and sometimes you will be allowed to go to the washroom and sometimes not. Well, this is quite detrimental. So at the initial stages, what we would want is the child to maybe have a card that they just have to walk up and put on the teacher's desk so the teacher is aware that they're going to the washroom.
So try to understand more about what the circumstances that might make those behavior a bit more difficult to demonstrate, and then try to problem solve that first.
Before we jump to the medication.
Yes, before jumping to the medications. Now we've sadly run out of time. It's been quite informative, and we do have a couple of requests for the forms you put up, the Talking Zone forms, and I believe you said that participants can email or contact you for copies of those.
I'm happy to do that. If it's easier, then I can send them to ADAA and they can distribute them.
Okay, so we will put up your contact information, or have the form be available. We'll figure out. We'll have a note to instruct a participant how to approach that. Thank you again, and thank you for everyone for attending this webinar. I know we didn't get to all of the questions, but I hope you find that this was helpful. So please let others know about this series and consider making a contribution to ADAA. Thank you, Dr. Mendlowitz.
Thank you very much for this opportunity.
Good night.